Welcome back to the Deep Dive. Today, we are shifting gears. We're moving away from the abstract, away from the philosophical, and we are dropping right into the high-stakes, adrenaline-fueled reality of the emergency room. We're doing something very specific for our listeners in the medical field, or honestly, for anyone who just has a morbid curiosity about the mechanics of the human body when the systems fail.
And we are really going to the source.
We are cracking open the absolute Bible of surgery.
We are indeed. We are looking at Baily and Love's Short Practice of Surgery, specifically the 28th edition.
And we are zooming in with laser focus on Chapter 78. The title is Deceptively Simple: Intestinal Obstruction.
It sounds simple, but it's a universe of complexity.
It is. Now, before we even start the engine, before we even think about touching a scalpel, I need to put up a massive flashing neon sign. A disclaimer.
A very, very important one.
We're interpreting this chapter to make it easier to digest, to help you revise, and, to give you mental anchors. This is not a regurgitation of the book.
Right.
And it is certainly not a substitute for reading the text. Do not try to operate on a patient based on what you hear in the next 40 minutes.
Please don't. I mean, you cannot learn surgery by osmosis or by audio alone. Think of this as your audio ready reckoner.
Yeah, a ready reckoner. I like that.
It's a primer before you hit the library, or, maybe a way to solidify concepts while you're commuting. The goal is to give you the framework so that when you read the chapter, the information sticks.
Exactly. So, Chapter 78, why this topic? Of all the things that can go wrong in the body, why is intestinal obstruction the hill we're climbing today?
Because it is the absolute bread and butter of emergency surgery. I mean, if you are a junior doctor, a student, or a resident, you will see this.
It's unavoidable.
It's completely unavoidable. And more importantly, the stakes are incredibly high. If you miss the subtle signs of obstruction, specifically the transition to strangulation, people die. It is that simple.
So it's not just a tummy ache.
Oh, far from it. It requires a really systematic approach because the difference between a patient who needs a nasogastric tube and some fluids and a patient who has a necrotic bowel that is about to perforate, well, that difference can be surprisingly subtle until it's way too late.
That sets the stakes pretty clearly.
Okay.
So our mission today is to decode the pathophysiology, the clinical signs, the management of obstruction.
And we're going to use metaphors. We've got some fictional case studies to make it stick.
And we're going to do something a little different. Check-in points.
Right. We'll stop occasionally and ask a question based on what we just discussed. And if you can't answer it, honestly, just pause the audio, rewind, and listen again.
It's all about active recall, right? Not just letting the information wash over you.
Exactly.
Let's get into it. The fundamental divide. The book classifies obstruction into two main camps. I like to visualize this as the difference between a blocked pipe and a broken pump.
That's a very accurate way to visualize it. I mean, the text formally calls these dynamic and adynamic obstruction.
Okay, let's unpack dynamic first. This is the blocked pipe scenario, correct?
Correct. In dynamic, or you'll hear it called mechanical obstruction, the bowel has a physical blockage. Something is in the way.
Got it.
But here is the key distinction that you have to understand. The muscles of the bowel, the peristalsis, they're still working. In fact, initially they aren't just working, they are working overtime.
They're trying to shove the content through the blockage.
Exactly. They're contracting vigorously to force the content past whatever's in the way.
So, using a car analogy, the engine is revving, the wheels are spinning, but the car is parked intimately against a brick wall.
Precisely. And that revving is clinically relevant. That turbulent, hyperactive movement is what causes the classic colicky pain. The gut is literally fighting the block.
And the block itself.
Yeah.
It can be inside the pipe, in the wall, or pushing from the outside.
Yeah, that's how the book classifies the causes. Intraluminal, inside the tube, like a big gallstone. Intramural, in the wall itself, like a tumor. Or extramural, something from outside the wall, like a hernia, or adhesions compressing the gut.
Okay. And then on the other side of the divide, we have the adynamic type, the broken pump.
Yes. Here, there is no physical wall. The road is completely open. But the engine is dead.
The peristalsis is just gone.
It's absent or it's inadequate. We see this in what's called paralytic ileus or pseudo-obstruction. The gut just goes on strike. There is no fight, just passive dilation.
Got it. Now, regardless of which type it is, whether the pipe is blocked or the pump is broken, something very bad starts happening chemically and physically inside the abdomen. The text describes a sort of toxic cocktail brewing upstream from the blockage.
It's a perfect description.
Walk us through the pathophysiology here. What is actually happening in that distended belly?
It's a vicious cycle that feeds itself. The bowel, proximal or, upstream of the blockage dilates, and it fills with two things, gas and fluid.
Let's talk about the gas first. Where is it coming from? Is it just like fermentation?
Some of it is. You get some hydrogen sulfide from bacterial overgrowth, which contributes to that foul smell later on. But the text notes that about 90% of the gas is actually swallowed air, mostly nitrogen.
Nitrogen is the problem. Why?
It is. Nitrogen is notoriously hard for the body to absorb across the bowel wall. It doesn't cross the membrane easily, so it just sits there, expanding the balloon.
Okay, but you said the fluid is the real killer.
It is. While the gas causes the distension and the discomfort, the fluid is what makes the patient hemodynamically unstable.
I was genuinely surprised by the numbers in the text regarding fluid. I mean, the amount of fluid we secrete internally is just staggering.
It is wild when you break it down. In 24 hours, your body secretes about 500 milliliters of saliva, 500 milliliters of bile, another 500 from the pancreas, and a full liter of gastric secretions.
Whoa, that's 2.5 liters.
It's 2.5 liters of fluid dumping into the gut every day before you even take a sip of water or eat a sandwich.
And usually that all just gets reabsorbed lower down in the small bowel and colon.
Exactly. It's a recycling system. But in an obstruction, two things happen. First, obviously the fluid can't reach the absorptive surfaces lower down because of the block. But second, and this is crucial, the distension of the bowel wall itself reduces its ability to absorb anything. The pressure inside compresses the veins, so that fluid just sits there. It is sequestered.
Sequestration, that's a key term from the chapter.
It means the fluid is effectively lost from the circulation. It's inside the body, physically, but it's physiologically useless. It's not in the blood vessels maintaining blood pressure. It's trapped in the gut lumen.
So even if the patient isn't vomiting yet, they are internally hemorrhaging fluid into their own gut.
Correct. And that leads to rapid dehydration, electrolyte loss, specifically sodium and potassium, and eventually hypovolemic shock. You can lose liters of effective circulating volume without spilling a single drop externally.
Which explains why these patients look so sick so quickly. They look just drained.
Exactly. They are, literally.
All right, time for our first check-in point. Listener, are you ready? Here are the question. Can you visualize why a patient gets dehydrated and goes into shock, even if they aren't vomiting?
Think about those liters of daily secretions and that concept of sequestration in the lumen.
Yeah.
If you can't explain that mechanism to a first-year med student, maybe just rewind to the toxic cocktail section.
All right, moving on. We need to talk about the big bad, the villain of Chapter 78, strangulation.
If there is one concept you take away from this entire deep dive, let it be this. Obstruction is a problem. Strangulation is a catastrophe.
Define it for us. What is the technical tipping point?
Strangulation means the blood supply to the bowel has been compromised. Simple obstruction blocks the food. Strangulation blocks the blood.
And how do we get from a blockage to cutting off the blood supply? What's the physics there?
It's all about pressure gradients. As the bowel distends with that gas and fluid we just discussed, the pressure inside the bowel wall rises. Now think about your basic anatomy. Veins has thinner walls and lower pressure than arteries. So, as the pressure in the bowel wall mounts, the venous return gets collapsed first. Blood can still get in via the high-pressure arteries, but it can't get out via the low-pressure veins.
So the bowel wall just swells up like a congested sponge.
Exactly. It becomes edematous and purple, the capillary pressure spikes, and eventually it gets so high that it overcomes the arterial pressure. That's when the inflow stops.
That's ischemia.
That's ischemia. The tissue starts to starve and die. You get what's called hemorrhagic infarction.
And I'm guessing dead tissue is not a very good barrier against the trillions of bacteria living in the gut.
No, it's terrible. The barrier function fails completely. The bacteria from the gut start translocating into the bloodstream, and you're on the fast track to septic shock and peritonitis.
The text mentions a specific mechanical scenario that is the highest risk for this, the closed-loop obstruction.
Yes. This is a critical concept to visualize. Imagine a sausage link tied at both ends.
Okay, picturing it. A sealed loop.
In the gut, this happens if you have a blockage at one point, say a tumor in the colon blocking the exit, and you have a competent valve upstream, specifically the ileocecal valve.
That's the valve between the small and large bowel.
Right. If that valve is competent, it acts like a one-way door. It lets stuff into the colon, but it won't let gas or fluid backflow into the small bowel.
So the pressure has nowhere to go. It can't go forward because of the tumor, and it can't go backward because of the valves.
Exactly. And the pressure builds incredibly fast in that closed loop. The cecum is particularly vulnerable here because of something called Laplace's law.
Remind us of Laplace's law.
Tension equals pressure times radius. The wider the bowel, the higher the wall tension for a given pressure.
Oh,
Since the cecum is the widest part of the large bowel, it takes the brunt of the tension. If you see a closed-loop obstruction, the clock isn't just ticking, it's racing. This is the highest risk for perforation.
there was another term mentioned in the context of strangulation, Richter's hernia. This sounds tricky.
It's incredibly deceptive. In a Richter's hernia, only a part of the circumference of the bowel wall gets trapped in a hernial orifice. Imagine pinching just the skin of a balloon, but not closing the whole balloon off.
So the tube itself, might still be open?
Yes. Gas and fluid might still pass. The patient might not be constipated, they might not be vomiting, they might just have a sore groin.
But that pinched piece of wall is dying.
Exactly. It is strangulating silently. It lacks the noisy, obvious symptoms of a full blockage, which is why it has such a high mortality rate. It tricks you into thinking everything is fine until the patient collapses.
That is genuinely terrifying. Okay, let's move to section 2, the cardinal features. If a patient walks in or is wheeled in, what are we seeing? The text lists a quartet.
The 4 pillars of diagnosis: pain, vomiting, distension, and absolute constipation.
Let's break them down. Pain.
In mechanical obstruction, it's colicky. It comes in waves. That's the peristalsis fighting the block, remember? It ramps up, hits a peak, and fades away. But, and this is a massive but, if that pain changes...
If it stops coming in waves.
If it changes from colicky to constant severe pain, that is a siren. Constant pain suggests the bowel is ischemic. It suggests strangulation. You never, ever want to ignore pain that settles in to stay. That is the peritoneum screaming for help.
Okay. Pillar 2, vomiting.
The rule of thumb relates to location. High obstruction, like in the jejunum, vomiting is early and profuse. You're losing bile and saliva immediately.
Makes sense.
Low obstruction, like in the colon, vomiting is a late sign. There's a lot more tube to fill up before it backs up that far.
The text uses a lovely word here, feculent.
It's unpleasant, but clinically important. Eventually, the vomit smells foul, like feces. It's not actually stool. It's small bowel content that has been fermented by bacterial overgrowth because it's been sitting there so long. It indicates a late-stage established obstruction.
Third sign, distension.
Look at the shape. Central distension usually points to small bowel. You might even see ladder patterns in the middle of the tummy. Peripheral or flank distension points to large bowel filling up the edges of the abdomen.
And finally, absolute constipation.
That means no gas, no stool, the factory is shut down. But remember the caveats we just discussed. A Richter's hernia, a partial obstruction, or even a gallstone ileus might still allow some gas to pass. Don't be fooled by a single fart.
Right. Let's apply this. We've cooked up a fictional case study based on the text. Let's call it Case Study A, the silent abdomen.
Okay, set the scene.
You have an elderly patient, let's call him Arthur, 82 years old, history of chronic constipation. He comes in with massive abdominal distension. He looks 9 months pregnant. The skin is tight and shiny. But here's the thing. He has minimal pain, and he hasn't vomited yet.
Okay, this is a classic presentation. The massive distension suggests a large bowel obstruction. The fact that he hasn't vomited suggests the blockage is low down, maybe the sigmoid or the rectum, and crucially, his ileocecal valve is competent.
So it's a closed loop.
It's acting like a closed loop. It's holding the door shut, keeping the reflux out of the small bowel, which is why there's no vomiting yet.
And why minimal pain?
Because the large bowel dilates slowly. It's capacious. It doesn't fight as violently as the small bowel. This fits the profile of a lower GI tumor, or perhaps a sigmoid volvulus. It's an insidious, slow onset.
Now, in the physical exam, the text says, hands on the patient. What are the specific anchors we need to remember?
First, look at the tongue. A dry, woody tongue tells you everything about that dehydration we discussed. Second, and I cannot stress this enough, check the hernial orifices. Lift the sheets. Check the groin.
You have to look.
You have to look. A strangulated femoral hernia is so easy to miss if you don't look, especially in an elderly woman, and it carries a really high mortality.
And the sound.
The stethoscope. Yes. In dynamic obstruction, you hear tinkling bowel sounds. It sounds like water pouring into an empty tin can. It's high-pitched. In adynamic obstruction, so in an ileus, you hear silence. A silent abdomen is an ominous sign.
Okay, check in. Question number 2. Stop the tape if you need to. What are the 4 cardinal signs of obstruction, and which one of them might be deceptively absent in a Richter's hernia?
Think about that pinched balloon analogy. If the tube is still open, what symptom goes away?
Section 3. The usual suspects. What is actually causing the blockage? The text has a clear number 1 cause, in the West at least.
Adhesions. If someone comes in with a small bowel obstruction and they have a scar on their abdomen, it is adhesions until proven otherwise.
These are basically internal scar tissue, right, from old surgeries.
Exactly. Fibrin bands that form after previous abdominal surgery. Appendectomies, hysterectomies, even C-sections. They can be flimsy webs or dense glue. They kink the bowel or compress it like a rubber band.
The management here is interesting because it's often, don't just do something, stand there.
Yeah, the phrase we use is drip and suck.
Grip and suck.
A nasogastric tube to suck out the fluid and gas, and an IV line to drip in hydration. We give them about 72 hours. If it's just adhesions, they often settle down on their own as the edema decreases. We really don't want to operate if we can avoid it.
Why not?
Because surgery just creates more adhesions. It's a paradox.
But that 72-hour clock is strict.
Very. Unless, of course, there are signs of strangulation. Then you operate immediately. You don't wait for the sun to set.
Next suspect, hernias.
We mentioned these. External ones, like in the groin, are obvious if you look. Internal ones, like bowel getting stuck in the foramen of Winslow, are rare and usually a surprise finding when you open the patient up.
Now let's talk about volvulus, the twist.
This is literally the bowel twisting on its own mesentery. And when it does that, it cuts off the lumen and the blood supply simultaneously. It's a double whammy.
The text highlights 2 main types, sigmoid and caecal. Let's distinguish them.
Sigmoid volvulus is the most common form of large bowel obstruction in certain populations. We see it in, for example, indigenous African populations because a high-fiber diet loads the sigmoid, making it heavy and prone to twisting.
And in the West?
In the West, we see it in a very specific demographic. Elderly, often institutionalized patients with chronic constipation, maybe on neuropsychiatric drugs which affect motility.
And visually, what does it look like?
Massive distension. On an X-ray, you see the famous coffee bean sign or the bent inner tube. It looks huge, filling the whole abdomen. It rises out of the pelvis like a giant balloon.
And the treatment is fascinating.
Yeah.
You don't always cut.
No, for sigmoid volvulus, you often decompress first. You put a flatus tube or a flexible sigmoidoscope up the rectum, and you untwist it from the inside.
Like letting the air out of a twisted balloon animal.
Exactly. It's incredibly satisfying. You get this huge rush of gas and liquid, and the patient feels immediate relief. But be warned, it often recurs, so you might need surgery later to fix that redundant bit of colon.
Contrast that with caecal volvulus.
Less common. It's the right side of the colon twisting. This is associated with a mobile cacum, a congenital lack of fixation. This one almost always needs surgery. You can't usually untwist that from below effectively or safely. The road is just too long.
Okay, next cause. Intussusception. I love this word. It sounds like a Christopher Nolan movie.
It is a bit like Inception, actually. It's the telescope effect. One segment of bowel slides inside the adjacent segment.
Let's use a case study here. Case study B, the screaming toddler.
Oh, this is a classic presentation. An 8-month-old male, he's fine, playing, then suddenly he's screaming, drawing his legs up to his chest in agony.
Wow.
Then it stops. He relaxes. He might even fall asleep or play again. He goes pale and listless. Then 20 minutes later, boom, it happens again.
It's episodic pain. It comes and goes.
Yes. That corresponds to the peristaltic wave trying to push the telescoped bowel further in.
And the diaper. The text mentions very specific signs.
Later on, you might see the red currant jelly stool. That's a mix of blood and mucus from the mucosal ischemia where the bowel is telescoped. It's a late sign, not a classic one.
What causes this in a baby?
In kids, it's usually idiopathic. The text mentions enlarged Peyer's patches, that's lymph tissue in the gut wall, maybe after a viral infection. The swollen patch gets grabbed by peristalsis and pulled in, dragging the rest of the bowel with it.
But in adults, it's a different story.
Totally different. If you see intussusception in an adult, be suspicious. It's almost always a lead point. A pathological structure like a polyp or a tumor that the bowel has grabbed onto.
So adults need surgery.
Adults usually need surgery to resect the cause. Kids can often be treated non-surgically with an air or contrast enema to push the telescope back out.
Finally, in our lineup of suspects, bolus obstruction, the weird stuff blocking the pipe.
Gallstone ileus is the famous one here.
But wait, gallstones are in the gallbladder. How do they block the bowel? They're tiny, and the bile duct is narrow.
Usually, yes. But sometimes a huge stone inflames the gallbladder wall, it sticks to the duodenum, and it erodes right through. It creates a fistula tunnel.
A shortcut.
Exactly. The stone bypasses the tiny bile duct entirely. It drops into the duodenum, travels all the way down the small bowel until it hits the narrowest point, the terminal ileum, and gets stuck.
And there is a specific triad for this on X-ray. I feel like this is a favorite exam question.
It is the ultimate exam question. Wrigler's triad. 1, small bowel obstruction signs. 2, pneumobilia, that's gas in the biliary tree because of the fistula letting air up into the liver. And 3, the calcified stone itself, visible in the right lower quadrant.
Fantastic. The text also lists some bizarre boluses.
Bezoars.
Yes. Phytobezoars, which are made of undigested vegetable fiber. And then there are trochobezoars, hairballs.
Hairballs in humans.
Yeah. This is Rapunzel syndrome, seen in patients with psychiatric conditions who chew and swallow their own hair. It forms a cast of the stomach and a tail that extends into the bowel. It's quite something to see.
Incredible. Okay, moving to section 4, imaging. We've ordered the X-ray. We're looking at the film on the light box. How do we tell small bowel from large bowel?
This is Radiology 101, but it is so essential. You look for the lines.
The lines.
In the small bowel, specifically the jejunum, you see valvulae conniventes. These are mucosal folds that go all the way across the width of the bowel. They look like a concertina or a stack of coins.
In large bowel. The large bowel has haustra. These lines only go partially across. They interdigitate, but they don't meet in the middle. They look chunkier, more spaced out.
So lines all the way across means small. Lines partway across means large.
Exactly. And always check the cecum size. If it's dilated to 10 or 12 centimeters, the text warns us about Laplace's law again. A 12-centimeter cecum is a ticking time bomb for bursting. You have to act.
And CT scans, are they just for confirmation?
Oh, no. They're the gold standard now.
Mm.
An X-ray tells you if there is an obstruction. A CT tells you where it is, what caused it, and most importantly, it hints at strangulation.
How does it do that?
We look for reduced enhancement in the bowel wall. That means no blood is getting there when we give IV contrast. That tells the surgeon, cut now.
Section 5. Treatment principles. We've diagnosed it. What do we do? We mentioned drip and suck.
Yes, nasogastric suction is vital. It decompresses the stomach. Remember, if the gut is blocked, the stomach is filling up. If that patient vomits and aspirates into their lungs, they get aspiration pneumonia. That can kill them just as fast as the obstruction.
So drain the stomach. And the drip.
Aggressive fluid resuscitation. You have to replace those liters of sequestered fluid we talked about. Use Hartmann's solution or Ringer's lactate. You need to correct the electrolyte imbalance before you even think about putting them to sleep for surgery.
Then comes the big decision.
Yeah.
The surgeon is standing at the end of the bed. To cut or not to cut?
The text quotes a classic surgical aphorism. The sun should not both rise and set on a case of unrelieved acute intestinal obstruction.
Meaning, don't sit on it for 24 hours.
Exactly. Don't wait. The indications for surgery are clear. 1, any signs of strangulation fever, tachycardia, constant pain, high white cell count. 2, a virgin abdomen, someone who has never had surgery, so it's unlikely to be adhesions. And 3, if conservative management with the drip and suck fails after 72 hours.
Let's say you open it up. You find a loop of bowel that looks purple and nasty.
Yeah.
You just cut it out immediately.
Not necessarily. You want to save bowel if you can. Short bowel syndrome is a miserable condition to live with. So we apply hot packs soaked in saline directly to the bowel for about 10 minutes. We give the patient 100% oxygen.
You just watch it.
You watch.
Yeah.
Does the pink color return? Is there a sheen? Can you see pulsations in the mesentery? If it perks up, you leave it. If it stays dead and black, you resect.
And if the cause is cancer, is the approach different?
It depends on the side. If it's a right-sided colon tumor causing the block, we usually do a hemicolectomy and join the ends together right there, a primary anastomosis. The blood supply is good, and the contents are liquid, so it heals well.
But the left side?
The left side is riskier to join in an emergency. It's full of loaded, solid stool, the blood supply is more tenuous, the risk of the joint leaking is really high. So often, we do a Hartmann's procedure.
Explain that.
You remove the tumor, you close the rectal stump sewing it shut, and you bring the proximal bowel out through the abdominal wall as a colostomy bag.
So stoma.
A stoma, yes. You can reverse it later, months down the line, but the priority is getting the patient off the table alive and not leaking feces into their abdomen.
Section 6.
Yeah.
Special scenarios. We can't cover everything, but let's touch on the extremes. Neonates. The tiny patients.
Just key phrases to remember here for your exams. If you see a double bubble sign on an x-ray, that's duodenal atresia.
Okay.
Meconium ileus. That is sticky, thick stool blocking the gut. Always think cystic fibrosis. Delayed passage of meconium. Think Hirschsprung's disease.
Back to the broken pump. Adynamic obstruction. Paralytic ileus.
This is so common after big surgeries. The bowel just goes to sleep from the handling and the anesthetic. It's a silent abdomen. Painless distension.
Do we operate?
No. There's no blockage to cut out. You would cause more harm. You treat the cause. Check the electrolytes, especially potassium. Low potassium hypokalemia paralyzes the gut. Fix the salts, wait it out, and it will wake up.
And finally, pseudo-obstruction. Or Ogilvy's syndrome. This sounds similar to ileus.
It is, but it's specifically the colon. It happens in unwell, elderly, hospitalized patients. Maybe they have pneumonia or a hip fracture. The colon dilates massively, but there's no tumor, no block. It's a nerve or autonomic issue.
But still dangerous.
Very dangerous because the cecum can still burst. We treat it with a drug called neostigmine carefully because it slows the heart, or we decompress it with a colonoscope.
We've covered a massive amount of ground. Let's head to the outro and do our final check-in.
Let's see what's stuck. Fire away.
Question 1. On an x-ray, you see lines crossing the entire width of the bowel. Is it small or large bowel?
Entire width. That's valvulae conniventes. That is small bowel.
Question 2. What is the classic triad for gallstone ileus?
That's Rigler's triad. Small bowel obstruction, pneumobilia gas in the bile ducts, and a calcified stone, usually in the right lower quadrant.
Question 3. What change in the nature of the pain warns you of strangulation?
When it shifts from colicky, coming and going, to constant and severe, that is your red flag. Do not miss that.
As we wrap up, I want to leave the listener with a thought. We've talked about pipes and pumps and mechanics, but there's something almost philosophical about the closed loop.
It really is a metaphor for any pressure system, isn't it? If you have input, but no outlet and no way to backflow, the system doesn't just stop, it destroys itself from the inside out. The bowel wall is resilient, but it has limits. Our job as surgeons or clinicians is to find that release valve before the system fails catastrophically.
And that is where we leave you. Your call to action. Go read Chapter 78. Look at the diagrams of the intussusception. Look at the coffee bean sign. This deep dive was the map. The book is the territory.
Good luck with the revision.
See you next time.